and welcome to another episode of Your Health Matters with Marshfield Clinic. I'm your host, Laura Kibbel. I'm pretty confident that we've all experienced aches and pains as we get older. But when do you take those aches and pains and turn it into an appointment that you need with an orthopedic surgeon? I'm very excited to have Dr. Robert Cagle, an orthopedic surgeon, with me today to talk about the services he provides. Thank you so much for being with us today, Dr. Cagle. Really appreciate your time.
Oh, thank you for having me. I'm happy to be here.
Excellent. So before we get started, I like to start with tell me where you grew up, where you went to college and medical school, and ultimately what brought you to Marshfield Clinic.
Yeah. So I grew up in the Midwest. I was born in Illinois, but I grew up in Indiana. So about the age of 10, we moved across the border from Chicago into Northwest Indiana. So I grew up in a town called Maryville.
Okay.
That's where I graduated high school and then went to Purdue for undergraduate and medical school in Indianapolis. And then did my surgical training in orthopedics at the Cleveland Clinic in Cleveland, Ohio. Came back to Indianapolis for a year of fellowship training in hip preservation and sports medicine.
Wow.
And after that was in private practice for a while. But a friend of mine, Dr. Rachel Randall, is here at Marshfield Clinic. And it was just the landscape of medicine is changing and more docs are going the employment route versus kind of being your own entrepreneur and owning your own business. So I decided that was kind of the route that I was going to go. And after speaking with Dr. Randall, she'd been here about 4 years. She's like, well, look at Marshfield Clinic. You know, they can do all the robotics and, you know, the joint replacement that you're specializing in. So I came and interviewed and just was blown away by the facility in Marshfield and decided, yeah, let's give it a try.
Wonderful. Well, thanks, Dr. Randall. That's fantastic. Yeah. We're so happy to have you. And how long have you been with us now?
Yeah, it'll be 2 years this August.
Wow.
So about a year and a half, I guess.
Yes. I remember when you started, and we were all so excited to have you join our orthopedic team. And I know you've been such a wonderful addition, and we're incredibly thankful to have you with us. So I'm excited about today's episode because people are always talking about as they, they say as they get older, their hips are, shot and their knees hurt and nobody ever really knows, what do I do with that? So just, start us off with, when would somebody see an orthopedic surgeon? What gets a person to, okay, I'm in pain, but no, now I actually need to see a surgeon?
Mm-hmm. Well, I mean, the first thing is it's hard to make someone better than pain-free. So if you're doing well, you probably don't need to see a surgeon per se, right? And I'm in the firm belief that not all problems need surgery.
Right.
Now surgery can be very effective, but it's usually not with rare circumstances, it's usually not the first line treatment. So, at Marshfield, we have plenty of people that are non-surgical musculoskeletal specialists, so I would say you can see a surgeon like me. That doesn't mean you're going to have surgery. Or if you're just like, hey, my knee's been hurting for a week, well, then we also have non-surgical specialists that if you feel more comfortable, like, man, is he just going to want to operate on me because that's what he does?
Right.
So you have those two options. So you could see a surgeon if you're like, well, this may need surgery. Why? Let's just bypass a middleman per se. Or you can say, that's really not the route I want to go. So I could see a non-operative, musculoskeletal specialist, get worked up. And if they need you to see a surgeon, then go that route. So you kind of have two options. For me, if you want to see me, I'm happy to see you. And it doesn't mean that you're going to need surgery.
So let's say now that somebody's tried all of the stretches, the home remedies, maybe ibuprofen, they're going to PT, OT, and all of those things just aren't happening. And, to make the pain or the tenderness or the swelling go away and it's prolonged and it's really affecting their life. And they make that determination. I am going to come and see you. Walk me through what a visit would look like. I think people often wonder, to your point exactly, I'm seeing a surgeon, they're for sure going to want to do surgery on me. But you said that's not always the case, but you are really that expert in knees, hips, and all of those sorts of things. What would a person expect in that visit with you?
Yeah, so the first thing, obviously, is you're going to meet the team and check in, get situated. They're going to ask you some basic medical questions. What medications are you on? What are your allergies? Have you had surgery in the past? What injury happened? Just some basic questions to kind of get a preliminary history. So then I'll review that with a medical assistant that got you in the room. And then typically I come in and the first thing is I sit down and just try to figure out, what kind of problem is this? I always want to take a personal approach to patient care. So, is this a big deal? Or is this something that I just want to get reassurance? So you can usually establish that just by how they're talking. So I'll just ask, hey, I'm Dr. Cagle, it's a pleasure to meet you. And within a few moments, I can usually determine like how big of a problem this is going to be. Sit down and then just go through a basic history. When did it start hurting? What are your symptoms? Is it swollen? Is it red? Is there, pain that keeps you up at night? Can you not play with your grandchildren? Whatever your complaints are. And once we kind of get a basic history, done, then next would be a physical exam. So if it's your knee, okay, well, can you show me the joint? Look for deformities. Look for any kind of swelling or something that, surgical incisions, anything that can just give a little inkling as what may be going on. And then you actually have to touch the person. So if you see a musculoskeletal person like myself, you are going to be touched and it may cause pain. I always apologize, but I have to examine you.
Exactly.
So I try to establish that it's not going to be intentional, but I have to examine you. So we'll take your knee through a range of motion, check for stability, and then we poke and prod with our fingers to try to figure out where your pain is because the anatomy is important. And then we usually, after doing a physical exam and history, I'll go through typically what your x-rays, your MRI, your CT scan that you're coming in with, and try to kind of get a basic determination of what's going on. So that's kind of what it would be. It'd be a history, physical exam, and then any kind of pertinent imaging that you might have.
Okay. So I am not, I have never been a bone nurse. I will be on the floor if I see anything bone related. And I've always wondered, how does a doctor determine you need a hip or knee replaced? What in that imaging versus X-ray, CT, MRI? I know you also perform, ACL repair and surgeries of that sort. But specifically for those repairs, what are you looking for to say, yep, this person would benefit from a replacement?
Yeah. So most of the time, I'd say 90% of the time or even greater, a plain X-ray is usually enough.
Okay.
For arthritis, right? And to kind of touch back on the point you made of when do I, quote, need joint replacement, right? There are instances where you do need one. So if you break your hip, right?
Okay.
That is a need because you can't walk, right? So that's a totally different problem than someone who has arthritis, let's say. So that's the first thing I try to establish with people. It's like, just because you're here, it doesn't mean you're going to need surgery. It's different than if you're in the emergency room because you fell off your roof.
Sure.
Right? So if you walked into clinic and you're having pain and discomfort, then I usually try to say surgery can be an option for you. If we see, bad arthritis on your x-ray and it's, debilitating, it's hurting your life, your lifestyle suffering, etc. So a plain x-ray is usually enough. Occasionally, though, you do need MRI or a CT scan. MRI is typically better for like ACLs or soft tissue problems. A CT scan gives you it's basically a three-dimensional x-ray. So it gives you much better bony anatomy. So most of the time it's an x-ray. More commonly than if that's not enough, it'd be an MRI or a CT scan, less commonly if you want to looking for bony abnormalities. But typically I would walk you through that and say, we'll get a screening x-ray right before you see me. That way I can go through it with you. And if we need more help, then we can order an MRI or CT scan or whatever. Okay.
So is arthritis the main reason that people get replacement? Is it anything else with cartilage or bone or anything like that? Can you explain a little bit more about when you say arthritis? What do you see on an X-ray, and what causes that?
Well, I mean, so the basic definition of arthritis, if you're an etymology nerd per se, arthros meaning joint, itis meaning inflammation. So in just plain terminology, arthritis is just inflammation of a joint. So if you're seeing knee arthritis, well, then we might throw the adjective on there of osteo, meaning bone arthritis.
Okay.
So typically what that means when people say I have arthritis, quote, arthritis, it's usually wear and tear. The cartilage is worn out, and what cartilage does is protect the bone. So the bone is like the struts in a house, and you need to protect them, similar like if you had a drywall. It's a good example, right? When that goes away and the bone is exposed, it's no longer a nice, smooth, gliding surface for that joint. Now it's like cobblestone road of grinding, catching, popping, all this, symptoms you may hear people complain about. So it goes from smooth cartilage to bumpy bone. And when people say, I have bone spurs, that's extremely common on an x-ray when you see bad arthritis. The bone is reacting to the loss of the cartilage, so it makes more bone to try to fix it. Doesn't work, unfortunately, but the body's trying to do something. So when you look at an x-ray, what you typically see is the joint space of cartilage shrinks.
Okay.
Right? So cartilage is invisible on an x-ray. So if you hear the term bone-on-bone arthritis, right? This cartilage has shrunk enough to where the bones now touch. That's bone-on-bone arthritis. So that'd be end-stage bone-on-bone arthritis. And then you have all these bone cysts and bone spurs that are commonly, as the body's trying to adapt to this state, doesn't work, but it's doing something. So that's the basic fundamentals of what is arthritis. It's basically the protective cartilage layer goes away from wear and tear, the bone is exposed and it reacts. And that gives you the deformity, the bone spurs, swelling, and you can see a whole host of symptoms, including pain, when you have arthritis.
That's wonderful explanation. And I have heard a lot of people say bone-on-bone arthritis. And that was perfect analogy. I love that, of the wall. And that's perfect. That makes imagining it much easier. So let's say you have a patient that technically, based off of the imaging, would qualify for surgery. What makes a patient a candidate for surgery?
So I would say, probably the 4 top reasons that I talk to people about that choose to have a joint replacement. So again, you don't need it usually, outside of I broke something, right? It's I choose to have this because probably the number one is my lifestyle is suffering. I can't play with my grandchildren. I can't play pickleball. I can't go for walks or whatever your symptoms are. 2 is I used to do non-surgical care, injections, therapy, braces, etc. Now they don't work. A close third is I can't do that because I have an allergy to cortisone. The braces don't fit. I got ulcers from taking too many anti-inflammatories. So non-surgical care doesn't work. 4, night pain. It keeps me up at night, So someone who is a candidate would be somebody who chooses to say, I don't want to live like this anymore. And I tell people it's basically a fork in the road you're standing at. So if you've gone through the non-surgical care or you're not a candidate for it, you can say, well, I can choose to replace my joint, or I can choose to accept pain and let my lifestyle suffer. So it's probably a personal choice to say, I am a candidate, and it's my job to educate you that, hey, you do have the diagnosis of arthritis, so you are a candidate if you choose to be.
Wonderful. Is there any patient that you would not want to do surgery on because they have other medical issues that could make their recovery less than ideal for them, that would actually put them into a worse situation perhaps than before they went into it?
Excellent question. Unfortunately, things don't always go as we plan, right? So you can have the best intentions and things sometimes don't go well. But you can minimize the risk for things going off course, right? So there's 2 kinds of risk factors, as we would say, for having a bad outcome. Modifiable risk factors like I smoke, or I use some kind of nicotine product, or I haven't been to the dentist in 10 years, right? And then
tell me why those 2 things matter for a knee replacement or a hip replacement.
Excellent question. So, any kind of nicotine. So I'm not going to lecture people on heart disease or lung cancer. I manage a surgical problem.
Right.
And what nicotine does, it isn't the smoking per se, or the dip, or whatever you choose. Nicotine is what's called a vasoconstrictor. So it limits blood. Well, how do you heal anything? Well, blood brings nutrients to heal and oxygen. So you're literally choking the surgical site by smoking or using nicotine products. So you take a blood vessel and squeeze it down. Increases infection rate by 500%.
Wow.
So that's a modifiable risk factor. And if you look at the evidence, if you stop using nicotine for 2 months, have surgery, give me another 2 months, so 4 months total, your risk goes back to baseline.
Wow.
And half of people that do that don't use nicotine again. The other half choose to say, well, I did my job, my knee's fixed, let's go back.
Okay.
And I'll be like, well, that's between you and your cardiologist or whatever.
Right.
But I don't want the infection risk, so that's what I require.
Okay.
Right? And to talk about dental, right? Well, your body is a very, very well-oiled machine, and it can fight off infections pretty well. So if you have an abscess, a cavity, some kind of problem in your mouth, your body is dealing with that. Now I hit you with a trauma, which is surgery. It's controlled. It's not rolling your car in a ditch, but it's a traumatic event for the body. So the immune system takes a hit. Well, if that bacteria can leak into the bloodstream, gets delivered to the knee at the time of surgery, well, metal is not alive. It's not having an immune system. So bacteria delivered to the knee replacement makes a very, very nice environment for bacteria to grow. So we've learned the hard way that if you ignore the dental problems of people, that can get in the bloodstream and cause infections. So whenever we want to talk about modifiable risk factors, it's to lower your risk for having a bad outcome.
So would it be accurate to say you require a patient to have a dental appointment within a year, 6 months?
Typically a year.
Okay.
So if you've had, typical checkups every year, that's usually enough. If you haven't seen the dentist in a while, we do need you to go to a dental office, and it's a simple form. Click the box yes, click the box no.
Okay.
And if there is a no, well, then we say, well, do whatever they need, get a tooth pulled, a crown, bridge, whatever they're requiring of you, then wait 6 weeks. Because we don't want that work to get infected, and then you have a knee replacement infection. So if it's a box yes, typically you're done. Box no, do the work, add 6 weeks, and then you're a candidate for surgery.
Excellent. That is wonderful information. What other reasons would you pause on doing surgery on somebody if they had other comorbidities that would prevent a good healing?
Yeah, so I mean, I don't like people, the first thing that people love to ask, am I too old for surgery? That's a very common one. And age isn't as important as your general health.
Okay.
Right? So that gets into the non-modifiable risk factor category. Some people, bad COPD, too bad, liver failure, whatever their medical problems are, they're just not healthy enough to have a high probability of a good outcome. Well, I don't want to hurt you, right? So when I take the Hippocratic Oath as a doctor, most people think my primary objective is to help you. That's actually wrong. That's the second objective. The primary objective is do no harm, right? So we have to take what we learn in our medical training to not inflict damage on someone. And if you're a high-risk patient because of your health, then it's more likely I'm going to harm you than to help you. So that would be in the non-modifiable risk category, is we have to, and I don't usually make that assessment. We usually have a medical team that works with you with your heart, lungs, kidney, etc. And they say, yep, you're an acceptable risk, or no, you have to get a heart cath or get your liver, back in shape, whatever the case may be. So there are a lot of medical conditions that I have no control over.
Right.
And it's just like, I'm sorry, I can't offer you surgery because the risk of me hurting you is so high. So those are more problematic for me to deal with because it's kind of out of my control. I can talk to you about smoking. I can talk to you about diabetes management. I can talk to you about good, food intake and having good nutrition, but I can't fix your heart. So
that's excellent. And I think that's a really important point, is it's not a simple surgery where there's no risk to it. It just because you're choosing to have surgery, you feel good, relatively going in, doesn't mean that there is no risk to it. And I really appreciate what you're saying, because I think that is important for patients. They're in this, I don't feel, or I can't get healthy because I'm not able to physically move like I wanted to in the past, and I need this surgery to get to this, but you also don't want to take them steps backwards either. And so I think that's certainly a conversation between you and the patient, but I think it's something for patients to really think about, to make sure that we certainly, don't want to make their situation worse. And more often than not, you certainly are making them in a much better position. But I appreciate what you're saying in making sure that they're in the best health as possible going into surgery.
it's so important.
Yeah.
Because we don't want to hurt people.
Right.
That's our number one goal, is we don't want to hurt you.
Right. So let's say now a patient has thought about it and decides, this is probably a little bit more than what I want to go through. Is there anything else that you can offer the patient to help with pain, with the arthritis, that is not surgical?
Yeah. So the two broad categories, I say, there's surgical treatment, non-surgical treatment. And in joint replacement, basically there's 5 things that you can think of that aren't surgery. So probably the one that comes to mind the most is a cortisone shot or some kind of injection. We have different kinds of injections now, but the workhorse is cortisone. So injections are number one.
What does that injection do? I'm sorry.
Yeah, so in all the injections that we have today are basically working on trying to tone down the inflammatory reaction in the joint. So nothing, despite what you may read, there is no known technology right now that can rebuild cartilage and take away bone spurs and fix deformities and all these things by squirting something into your knee. right? So everything that we have today is working on just trying to decrease the inflammation in the joint. So whether it's cortisone, PRP, the hyaluronic acid, stem cell treatments, all the stuff you read about today,
Right.
it's trying to tone down the inflammatory response in the joint to basically treat the symptom of pain. It doesn't treat the deformity or the cartilage loss. So that's what injections typically do, or try to reduce the pain and inflammation in the joint. Okay. Second thing that you can try is physical therapy. We know that a strong, flexible joint with the same x-ray compared to a weak, stiff one, it typically hurts less. So physical therapy can be a powerful tool. It doesn't work for everybody, but it's something to try. Bracing. Now, that's not available for hips. It's hard to brace your hip. But for knee replacements, there's a whole host of different kind of arthritis patterns that can be treated with bracing. May not work, but it's something you can try. Now, there is pain management. Now, I don't do chronic pain management with narcotics. I think that's, if you're getting to the level where I need narcotics to get through my day, you're probably looking at a joint replacement, because the side effects that go along with chronic narcotic use are just so vast, and they're dangerous.
Yep.
So I try to counsel people, I don't prescribe narcotics unless it's after surgery. And I really try to say, please don't petition your primary care physician or a pain specialist for oxycodone because you have an arthritic knee.
Right.
So when I talk about pain management, it's usually an anti-inflammatory an anti-inflammatory based regimen like ibuprofen, Aleve, something like meloxicam or Celebrex, that's prescription, in conjunction with Tylenol, which is a non-narcotic pain reliever. So, or you can do a topical pain relieving program like Voltaren gel is very popular, or some kind of biofreeze. I mean, there's dozens on the market today. And probably the most powerful one that's non-surgical is lifestyle changes. So my father, perfect example, was extremely overweight. And it's simple physics. The more force you put through the joint, the faster it wears out, the more pain you feel. So he lost over 100 pounds, and same x-ray, bad knee, doesn't hurt as bad, I don't need my knee replaced. So, and you can choose like people that are, die-hard runners. We've never proven running causes arthritis, but we do know if you have it, it makes it worse. So that's where it's like you can still work out, but maybe need to do ellipticals or swimming or cycling. So you can modify your life around your lifestyle, I should say, around your knee pain.
Right.
And if that doesn't work, well, it's either live with it and decrease your lifestyle,
Right.
or fix the problem with a joint replacement.
Right. I know one thing that I'm reading the minds of the people at home. Hot or cold on the pain?
Yeah, so if you look at the evidence, cold therapy or cryotherapy is anti-inflammatory.
Okay.
Okay. So right after surgery, we usually say keep it cold for a week. Try to minimize that inflammatory response of swelling, right? Now, anecdotally, meaning patient-specific, whatever works for you. So if you haven't had surgery and you find that putting a hot pad on your thigh helps your hip pain, go for it.
Okay.
The next person might say, no, that doesn't work. You need to put an ice pack on it. Who's right or wrong?
Right.
Well, they're both right.
Okay.
Because it's all about symptom relief. That's the difference between surgery, it fixes a problem. Non-surgical treatment treats the symptoms of the problem.
Right.
So that's why I would say hot or cold, you tell me.
So tell me what has changed in the OR that has advanced the rate in which patients recover from the surgery.
Yeah, probably the number one is expectation, I would say, is, the surgical approaches have advanced, the anesthetics that we use have advanced, but the power of the mind is real. And if you go into surgery saying, hey, my brother went home same day, or my nephew, or whoever, I've seen people successfully do it, and you're primed to say, I don't have to be in the hospital a week. So I think that's where it starts, is saying it's a safe procedure to be done, quote, outpatient. And you can say, well, I will go home and recover. So the definition of recovery versus stability, right? So the hospital is for stability. You become stable. So you just have surgery, we have to make sure you're stable to go home to recover. So the idea of getting discharged the same day of surgery or 100 days after surgery, it's the same criteria. Are you eating? Are you drinking? Are you using the bathroom? And can you successfully navigate stairs? That's basically the criteria to be discharged the same day.
So now I'm home. How long do I have in recovery? What are we looking at for, are they going to physical therapy? How long does that take? when do I feel like I'm kind of back to full range of motion following surgery?
Yeah. So I would say let's start with the knee replacement.
Mm-hmm.
Knee replacements typically are a little more painful than hips. I don't have a great explanation why. But
Okay.
you talk to any joint replacement specialist, they'll always say knees are a harder recovery than hip replacements.
Mm-hmm.
Okay. So the knee replacement, it's all about minimizing scar.
Mm-hmm.
The first thing I do when someone says I want surgery, I don't go through the surgery, nuts and bolts yet. It's like, let's talk about the recovery first,
Right.
because I know that people are going to start to zone out. And I want the one thing that they're going to remember is what to do right after surgery.
That's great.
So it's so important to realize that with a knee or even hip, minimize your scar tissue. How do you do that with motion? Well, motion's going to hurt.
Yeah.
And the blocks wear off. So this is where the mindset comes in of saying, pain is not going to kill me.
Mm-hmm.
I have to do my therapy anyway.
Mm-hmm.
And when I do a knee replacement for someone, I tell them it's hourly. So when you're at home, the next day after surgery, the clock starts that day, and it's every hour while you're awake. So 16 times a day, you do 3 minutes of therapy. You do a minute of a walk to warm up. You sit down in a chair. You get your knee straight. That's number 2, and it's going to hurt.
Mm-hmm.
And then you get your knee bent, number 3. And you do that over and over again. And the key is minute progress daily. You don't have to get all your motion the first day,
Right.
but by 6 weeks. And I tell people, I hate numbers. Don't tell me your therapist told you 130 degrees. I don't know what that means because I
Right.
don't know how they're measuring it.
Yeah.
But everybody can answer a yes or no question of, can my knee get straight while being able to take my calf to my thigh?
Okay.
So you bend your knee enough to get your calf to your thigh with the ability to get it straight. That's a not stiff knee. If you can't do that, you're stiff.
Okay.
And that is the goal of the physical therapy in the first 6 weeks after knee replacement. Minimize scar tissue. Scar tissue equals pain. Stiff knees hurt forever. So I tell people, if you're going to sacrifice your therapy today, yourself is paying that bill tomorrow.
Exactly.
So it's better, you might as well just suck it up today
Yep.
and then have a good outcome, because I can't control that.
Right.
I can do the best surgery for you. But if you go home and say, you know what, I'm going to take the day off,
Right.
you have to pay that bill later on.
Right.
So that's what I say is the first 3 months are so critical. The biology of scar formation is 3 months.
Mm-hmm.
That's when your body is making scar, in the first 6 weeks especially. So I want full motion out of your knee replacement by 6 weeks. And then the second 6 weeks, you maintain that motion. And what do? The exact same thing. Every hour, you walk, you straighten, you bend. I try to keep it simple,
Mm-hmm.
okay? And the first 6 weeks is worse than the second 6 weeks if you get your motion. And I try to avoid a lot of strength training because that's going to make it swell.
Mm-hmm.
So a lot of people, I like me included, are
Yeah.
very bullheaded and say, I want to get back to life.
Right.
It's like, this is a tortoise race.
Right.
Don't become the hare. Right?
Okay.
So slow down and you get better faster in the long run. If you jump the gun and try to do a lot of strength training, you're going to swell up the knee and then you can't bend it. And guess what? Your knee heals where you put it.
Mm-hmm.
So if you get a swollen knee like a big beach ball and you can't bend it past 90 degrees, it's going to heal that way. And now you have a stiff knee for the rest of your life. That's going to be painful.
Mm-hmm.
So get motion. If your body lets you do strength training,
Mm-hmm.
okay. But if it says no, you stop. And for 3 months, that's 75% of the recovery process is no stiffness in your knee at 3 months. And then you have the rest of your life to work on strengthening it.
Excellent.
So the actual book answer is you're about 75% recovered at 3 months, but up to a year for all the dust to settle, to rebuild your strength endurance. And the other thing I mentioned is the competitive cyclist.
Mm-hmm.
Their recovery is longer
Right.
than the little 80-year-old that just wants to go shopping because
Right.
the bar is set high.
Exactly.
So when people say, how long until I recover? It's kind of a trick question because it's like, well, what's your life?
Right.
If you're a competitive athlete, it might be 5 years before you're
Right.
fully recovered because you've been dealing with this deformity, all this pain, you've gotten weak, and now you want to rebuild that to where you used to be. It can take a long time.
Does a patient need a referral to see you in the office?
Not unless their insurance requires it.
Okay.
No. There are some insurances say, well, I'm not going to pay for your specialist visit unless your primary care doctor refers you.
Mm-hmm.
I think that's madness, but
Yeah.
I have no control
Right.
over the bureaucracy of an insurance company.
Yeah.
I would say if you're like, hey, my knee hurts, I saw this episode with Dr. Cagle, I want to see him.
Yeah.
Pick up the phone, give us a call, I'll be happy to see you.
Excellent, excellent. Thank you so much. This was an incredibly informative episode. I know I learned a lot, and I will be happy to pass the information on. And I'm certain that patients will be coming to see you. So thank you so much for your time, and thank you everyone for joining us. And I will see you again next month. Until then, be well, my friends.